Episode 39, Abdominal Rash in a Soccer Player. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide practice questions. Today's case, a 19-year-old male Division I collegiate soccer player. He approached the athletic trainers in the athletic training room with one complaint, a rash on his abdomen. Specifically, it was described as a maculopapular rash on the lower and upper right abdominal quadrants, extending to the right flank. He was otherwise completely asymptomatic. He denied fever, sore throat, fatigue, or lymphadenopathy. Only complaint was the rash. His past medical history was otherwise unremarkable. He had no known drug allergies and no history of similar skin conditions. He was not currently in treatment for any injury or illness, and he had no recent use of medications, no prescription, over-the-counter medications, or illicit substances. On physical examinations, the authors describe a normal examination. The vital signs were normal. He was afebrile. He had no lymphadenopathy, no palatal petechiae, no pharyngeal exudate, no abdominal tenderness, just the maculopapular rash on his abdomen. The athletic training staff referred him to the University Health Services for further evaluation. Okay, my differential diagnosis, obviously I'm thinking viral exanthem, possibly some other types of dermatitis, including infectious dermatitis. I want to recognize the authors, Drs. Nelson, Morrison, and Smith. This was published in the Open Journal of Clinical Medicine Case Reports in 2019. I am Scott Hall, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in 2026, and I hope you will join me on the journey. This podcast is for educational purposes only. Okay, he goes to the Student Health Center. A rapid strep test and a monospot were ordered. The monospot came back positive, and additional serology showed positive Epstein-Barr virus specific IgM and IgG antibodies were positive, which is consistent with a primary Epstein-Barr virus infection or mononucleosis. The physician instructed the athlete to cease all soccer-related activity for 3 to 4 weeks. Further recommendations included rest, maintaining fluid intake, and using over-the-counter medications as needed. The rash itself was non-pruritic and was not causing any discomfort and was treated supportively. No additional imaging was recommended to evaluate for splenomegaly. 1 week after the diagnosis, the athlete started developing mild symptoms consistent with mononucleosis, including pharyngitis, malaise, and myalgias. These were managed with over-the-counter anti-inflammatories and resolved by the end of the second week post-diagnosis. At his 3-week follow-up, the athlete was asymptomatic and the rash had significantly improved. The physician cleared him for a supervised 1-week conditioning program with the important caveat of avoiding activities that could result in contact to the abdomen. The conditioning protocol was structured and progressive. The first 3 days focused on low-intensity aerobic exercise. Days 4 through 6 introduced moderate-intensity cardiovascular training and body weight resistance exercises, including squatting, lunges, planks, push-ups, and burpees. On the final day, sprint training and high-intensity body weight exercises were introduced. 4 weeks after the initial diagnosis, the athlete was cleared for full participation in soccer. No complications occurred during the return to play protocol. The rash persisted for about 2 more weeks after his return, but eventually fully resolved. Couple of key takeaways from me. Mononucleosis in athletes is caused by the Epstein-Barr virus and most commonly affects those 15 to 24 years of age. The central concern in management is splenic rupture risk, which drives return to sport decision making. Current guidelines recommend avoiding contact or collision sports for at least 3 weeks from symptom onset, with return individualized through shared decision making. If you look at references 2 and 3, they're the most current guidelines. Mononucleosis may have an atypical presentation like this one. The overwhelming majority of skin eruptions associated with infectious mononucleosis in the literature are linked to antibiotic use, most commonly amoxicillin or ampicillin. The classic scenario is a young person who presents with a sore throat, gets diagnosed empirically with strep or presumed bacterial pharyngitis and receives amoxicillin and then breaks out in a diffuse maculopapular rash a few days later. That rash will then prompt further workup and eventually a diagnosis of mononucleosis is made. But in this case, there were no antibiotics. There was no preceding respiratory illness, and the rash was the presenting and initially the only sign of disease. I searched the literature and I found one similar case report which included a picture of the rash, which I'll include in the references. The authors with this case did not include a picture of the rash. The classic triad of infectious mononucleosis, including fever, pharyngitis, and posterior cervical lymphadenopathy, is present in 70 to 80% of patients, with other common features including fatigue, malaise, exudative tonsillitis, headache, and myalgia. Coexisting streptococcal pharyngitis should be evaluated as it requires separate treatment. Third key point is to understand the initial laboratory testing. I'm certainly going to get a question about this on my examination, so I'll just briefly talk about some laboratory testing. Initial labs should include a CBC with differential looking for greater than 50% lymphocytes and greater than 10% atypical lymphocytes, and a rapid heterophile antibody test, also known as a monospot test. The monospot test has an 87% sensitivity and 91% specificity, but carries a high false negative rate in the first week of illness. Elevated hepatic transaminases are found in nearly 100% of confirmed cases in collegiate athletes and can support the diagnosis when the monospot is negative. Epstein-Barr virus-specific antibody testing, which was obtained in this case, includes testing for the IgM and IgG portions, and I've seen different labs use different terminology, but you may see it described as an EBV antibody or VCA, which stands for viral capsular antigen. These antibody tests are sensitive and specific and should be considered when clinical suspicion remains high despite a negative monospot test, particularly in athletes where an accurate diagnosis will affect the return to play timing. Fourth point is return to play decisions should follow current evidence-based guidelines. At a minimum, 3 weeks of restriction from contact sports is recommended, followed by a gradual return with close monitoring, as exemplified in our case. One should individualize the protocol based on symptom severity, sport-specific risk, and the athlete's clinical trajectory. I want to talk a little bit about splenomegaly because thinking has changed somewhat in the decades that I've been in sports medicine. Splenomegaly is nearly universal in acute infectious mononucleosis, and physical examination is unreliable for its detection. Splenic rupture occurs in less than 1% of patients, with the risk peaking approximately 2 weeks after symptom onset. Critically, most splenic ruptures are atraumatic at about 80% and predominantly affect young men, and in the majority of cases, the diagnosis of mononucleosis was made only after the rupture event. There are no data correlating spleen size to rupture risk, and single-point spleen measurements have limited utility given the wide variability in normal values. The return to sport guidelines published by the American Medical Society for Sports Medicine and the American College of Sports Medicine provide the most current guidance. So from symptom onset through week 2, one should be restricted from athletic participation, as we discussed. After week 2, athletes who are afebrile and have adequate energy and show clinical improvement may begin supervised non-impact low-intensity aerobic activity. Contact or collision sports and heavy exertion should be avoided for at least the first 3 weeks, with the AMSSM recommending 3 to 4 weeks in their published guidelines due to the risk of splenic rupture. Full unrestricted return to play should not occur until symptoms have fully resolved. If early return to contact is being considered, serial ultrasound imaging can be used to monitor the size of the spleen to determine stability or decreasing size. Premature return to heavy exertion before 3 weeks may prolong fatigue and impair performance. Factors to weigh in the return to play decisions include sport-specific contact risks, athlete age, timing within the season, medical comorbidities, and psychological readiness. The management for mononucleosis is supportive, so in terms of treatment, routine use of corticosteroids and antiviral is not generally recommended. Corticosteroids can be considered for complications such as airway compromise from tonsillar hypertrophy, severe thrombocytopenia, hemolytic anemia, or myocarditis. Thank you.